This is the last module, and it's about treatment of mental illness. So lots to learn, so let's go. So the module starts off about just generally talking about treating psychological disorders. They're giving you some vocabulary here. The first word, deinstitutionalization, that's a mouthful, right? That's the process that's already begun in the 20th century of moving people with psychological disorders out of mental institutions, institutional facilities, and allowing them to go back home. How do they do this? Well, with the advent of medication, right? So a lot of these patients that had to be in hospitals now with medication can go home and live with their families, which that's really great news. Another couple of words here, psychotherapy and biomedical therapy, two different kinds of therapy. When they think of psychotherapy, think of the talking therapy, right? And then biomedical therapy would be anything that involves like drug treatment. And so really, in therapy, if you're taking medication, it's really important that the person talk to their doctor while in therapy to talk about also how they feel in the medication. So when a person's given medication, it's not like it's one and done deal where, okay, go home with your medication. No, they're supposed to take their medication and see a counselor or a therapist regularly to talk about what's happening in their lives, talk about their state of mind, but also talk about how they feel on the medication. So I like teaching things in themes because it helps us keep the information organized in our heads. So the first type of therapy we're going to talk about is psychoanalysis, and of course, Freud is back. The goal of classic psychoanalysis, according to Freud, is to kind of achieve insight into the mind of his patients, and he would allow them to free associate, lay down on that couch, and just talk about anything that comes to mind with the hopes of him achieving some insight as to what their problem is. Talk about maybe, dream interpretation or the interpretation of their free associations. That's what the therapist's role is in psychoanalysis, to listen and to put together patterns from their responses. So the goal of psychoanalysis is to analyze and interpret. So with regards to dream analysis, remember those two words, we've talked about this before. He would want to examine the manifest to uncover the latent. You heard what I said, examine the manifest, what the person sees in their dream, and then Freud would uncover the latent, the hidden desires, the unconscious meaning of the dream. Now there's two other words here that are very important, transference and countertransference. One is good and one is very, very bad. Transference is actually good. It might not feel good at the moment, but it's good. When the patient lashes out at the therapist or gets angry or whatever emotion is projected onto the therapist, that's called transference. And it's the therapist's job to interpret that. But countertransference is when it goes the other way, when the therapist is transferring their emotions onto the patient, and that is not a good thing. Okay, so this is a picture. It's actually a museum that kind of goes around, sets up Freud's office, how it originally was. And Freud was seated over here in that seat behind those pillows. And he would write notes on whatever the patient was saying while they were free associating, laying down, relaxing on their couch. So moving away from psychoanalysis, we're going to talk about humanistic therapy and their view on therapy in general. So what's a humanist view on therapy? And if you know humanism, like you should know humanism by now, you could probably just guess, right? If they believe the person is born good and their hang-ups have to do with their environment, the humanist, their take on therapy is going to be all about making the patient feel good, raising self-esteem, making them reach their potential. That's going to be the focus of the humanistic style. Now, some of the humanistic targets is making sure the patient achieves growth and self-acceptance, focusing on the present day, what's happening in their lives right now, and also a strong focus on the conscious mind. Now, that's different than psychoanalysis, isn't it? Because psychoanalysis psychoanalysis focuses so much on the past, childhood, and the unconscious, the humanist is different. They're going to focus more on the conscious mind, what's happening with that person today. And it's called person-centered or client-centered therapy because the humanist believes that we need to target our efforts on the client. The client can lead the way, right? The client can talk about their view on getting better, and then the therapist's job is to kind of follow the lead of the client. It's person-centered or client-centered therapy. Very different from psychoanalysis, isn't it? And remember, the whole view of the humanistic style is making sure that the patient feels good and is kind of achieving their goal to meet their potential, but also giving them unconditional positive regard. So the psychoanalysis has their tools. Some of the tools that a humanist would use are things like active listening. And what is active listening? Active listening is paraphrasing, like, so what you're saying is, and then paraphrase to make sure that you're understanding the message clearly. Also, they're going to invite clarification. What might be an example of what you just said? Asking follow-up questions to the patient, to the client, about what they just said, like follow-up piggyback questions, asking them more details, and then also having the patient reflect on their feelings. That sounds frustrating. Showing that you empathize with your patient or client, mirror how they're feeling. If they're feeling frustrated and sad, then you empathize with the frustration and the sadness. So it's important that you understand, like right here, the difference between the humanistic style and the psychodynamic style. How would a behaviorist approach therapy? If you remember behaviorism, you know that they believe that we're born nothing. We're born a blank slate, and then the world shapes us and creates us. So everything's about training and untraining, right? So a behaviorist or a behavior therapist would take a behavior that you have, a complaint, a bad habit, something that you want to change, and they're going to help you change it using the behaviorist style. It could be using classical conditioning, operant conditioning, or even social learning theory, modeling. So everything that you learned in the behaviorist chapter can be applied here. So in a way, this chapter is coming full circle. You're using your knowledge that you've learned in the past in psychology, and you're applying it to therapy right now. So here are some, this should feel like a review. Here are some training techniques or different learning techniques under the behaviorist umbrella. Like the first one is systematic desensitizing. That's using or treating a specific phobia and associating it with pleasant feelings. So systematic desensitizing is exposing a person to what they're afraid of, but also pairing what they're afraid of with something that's pleasurable or something that's nice or joyful or happy to get them to get rid of that negative association. Now, aversive conditioning is actually the opposite. It's pairing something bad with something unwanted. So for example, and I have it right, I can't get my fingers right here next to me, there is a pill for alcoholics, and this pill's been around for a while, but you have to take the pill, and if you drink alcohol with the pill, it causes really bad stomach upset. Now when you pair the two together, right, that's aversive conditioning, right? You're pairing alcohol with pain so that you have an association with alcohol and pain to get you to stop drinking alcohol. See how that works? That's aversive conditioning. So you're pairing something bad with something unwanted to get rid of it, right? Systematic desensitizing, you're pairing something good with something unwanted to get rid of the bad association. Do you see the difference? So in class, I showed several therapeutic techniques used by different therapists, treating someone with a specific phobia like spiders, treating someone with agoraphobia, and you're seeing different techniques right before your eyes. So one of the videos that I showed in class is a girl named Sonata who has a lot of trouble getting into the elevator, and she needs to get into an elevator. She lives in the city, so she works up on the 12th floor. She lives up on on the 15th floor. You can imagine not being able to take an elevator could really impede her life. So they're showing you by using flooding or extinction, like extinction procedures on Sonata, to get her to desensitize to an elevator. And in the span of a week, she rides an elevator over 300 times. That's flooding, right? Getting her in the elevator up and down for an entire week. She grew completely desensitized to it, and she was able to get in an elevator. And not just one elevator, but elevators from different buildings all over the city. Operant conditioning techniques are really great to use for any kind of behavior modification. And remember that token economies, we talked about this also in the behaviorist chapter where we learned about learning principles. Token economies are great ways of imposing rewards, and they can lead to a greater reward later. And advocates believe that people will shift from the tangible rewards to one that's a real life social approval kind of reward. So it's not like you always have to keep providing tokens. Eventually, kids will know that this behavior is good, and because it's good, they want to continue to perform it because they know that they're going to get recognized for it later. So is it right to control human behavior? Critics will feel that it's kind of authoritarian, and it advocates that feeling that effective treatment and improved life does justify this temporary deprivation, this temporary manipulation. So you're looking at the greater good here. Is it good to manipulate behavior, manipulate somebody else? Probably not, but if the greater good is for them to get their life back and to be able to function in life, well then, right there that tells you that maybe these techniques are definitely valid. I don't even have to teach this. Cognitive therapies, you can imagine what that's about. It's about how you think. So remember, cognitive therapies are all about how you think, and thinking influences feeling, and feelings influences behavior, right? So if you look at this little model here about losing your job, if you lose a job and your internal feeling is that you're worthless, that you deserve this, and you beat yourself up and you feel guilty about it, that does lead to things like depression. But if you lose your job and your internal belief is, well, you know what, a lot of people have lost their job. This economy has been really sluggish. That boss, he favored somebody else and gave someone else the position. If you look for reasons that are not your fault and you don't impose guilt on yourself, this doesn't lead to depression. So you see, the same thing can happen to two different people. They lose their job, but it's how they think about it that leads to depression or not. If you're a good friend, you kind of already do this, and this is called rational emotive therapy. Have you ever had like a crazy irrational friend that's really having a hard time at the moment, and then you try to help them? What do? You talk to them about logic. You ask them questions that are logical. You say things like, well, what evidence do you have that they're cheating? Right? And you ask them questions like that are logic-based. This is when you're devoid of logic and you need someone to help you find the logic. That's rational emotive therapy, and that was done by Albert Ellis. Now, self-efficacy, we talked about this also, is a person's belief that they can achieve a goal, and that comes from self-esteem and self-worth. So if you feel bad about yourself, your efficacy is going to be pretty low, right? If your self-worth is low, your efficacy is low. And Aaron Beck talked about cognitive, like maladaptive schemas. Maladaptive means abnormal or atypical, and schemas mean a framework of thought. So if you have maladaptive schemas, that means your thoughts are weird and strange and maybe illogical. Like arbitrary inferencing is saying like, hey, they're all making fun of me. What evidence do you have they're all making fun of you? They're speaking Spanish. Well, what evidence do you have that they're speaking about you? That is a maladaptive schema. Another one is dichotomous thinking. Have you ever heard someone say, well, if he doesn't call me in 2 minutes, that means he's cheating? Like two variables that are completely strange. If he doesn't call you in 2 minutes, he's cheating? That's dichotomous thinking. It's this all or none kind of thinking that is not logical and almost sounds a little paranoid, doesn't it? Your thoughts are wrong. We have to fix your thoughts so you can start feeling good and acting good, like behaving well. Okay, so not just a pretty chart, because you know I love charts, but this is a study tool. So make sure that you go over the different types of techniques and like the directives of the therapist. Know the differences. You know, sometimes good things come from problems. And here was a problem that happened many years ago where there was not enough doctors to go around. There was not enough nurses to help. A lot of people with similar problems were, you know, having trouble finding a therapist. So what they started doing is grouping people with similar problems and assigning them one person like a therapist. And that's how group therapy came to be. It was really kind of like, you know, a product of necessity, right? They just needed it at the time. And this was a way to kind of like resolve a problem that they had. But it ended up being a really great thing, because when you get together with people with similar problems, not only are you making friendships and you're bonding with others, but you don't feel so alone. And you talk to people about how they're coping with their problem and how they're coping with these issues. And it kind of helps a person not just, you know, feel like I'm alone in this problem, but you feel like, okay, let me try what you're doing, because, you know, you have firsthand experience and you get me. I'm going to try to emulate that. And that's how it helped a lot of people. So group therapy was really sprung up out of an issue, like a problem that they had, but it turned out to be a really great thing. And so you can do group therapy, and that could spill over into family therapy. Self-help groups, a lot of these are not even directed by a doctor or a physician. They're directed by, again, people with similar problems. Someone takes the lead. And you could look at groups like Mothers Against Drunk Driving, right? There's no therapist there necessarily. I mean, sometimes there could be, but Mothers Against Drunk Driving are people that have these horrible experiences. They've lost a loved one due to drunk driving, and then they get together and they talk about how they cope with this horrible trauma in their lives, and it helps other people. It just does. So yeah, sometimes good things could happen. So make sure that you study this chart also, that kind of breaks down the therapies for you, the presumed problem, the aim of the therapy, and the technique that's being used to remedy. Okay, so how effective is therapy? And this is where they're talking about the evaluation of these different psychotherapies. Now, the client's perception, remember, a lot of it is like self-fulfilling prophecy. The client's perception, they might feel better after therapy because they think they should feel better after therapy, right? They fulfill the prophecy of being better because they're thinking, I'm going to therapy, I must feel better. So the client's perception is that they might claim that they feel better just because they should feel better, right? And the clinician's perspective is that maybe they're experiencing some kind of confirmation bias, almost like unconsciously perceive like these illusory correlations for positive patient outcome. And that's definitely something that the patient probably helps with too, by saying, oh, I'm feeling a lot better, thank you so much. And so now the therapist is getting kind of like the feedback that things are going well. So that's the clinician's perspective. But you know what, if you look at the general evidence, does psychotherapy work? Yes, in general it does. And here's what they're finding. People can go to therapy and they get better, or people can choose not to go to therapy and they can also get better. But here's the difference. People who go to therapy, they get better faster and they stay better longer because of that connectedness you have with that therapist or someone that is knowledgeable and can help guide you, and you kind of stay on the right path as opposed to falling off the wagon and maybe doing the wrong thing. So in general, yes, therapy is helpful, but do you absolutely need it to get better? No, of course not. Some ethics and ethical guidelines in therapy, according to the American Psychological Association, is no harm should come to your client, right? Everything, the target goal is to benefit the client. Number 2 is fidelity and responsibility. That client trusts the therapist, and the therapist needs to earn that trust and do right by them by being honest and truthful, making sure that everything is fair, promoting justice and respect, keeping keeping the rights private and anonymous, right? Everything confidential. These are things that therapists have to do to make sure that they're guiding by ethical guidelines. Biomedical treatment sounds like what it is. It's about drug treatment used to treat psychological disorders. So these are some major drug groups. You have your antipsychotics that treat schizophrenia, you have your antidepressants that treat depression, you have anti-anxieties that treat anxiety, and of course mood stabilizers that treat bipolar. All this is the study of psychopharmacology, and that's a big word that means that we're studying the effects of drugs on behavior and the mind. So antipsychotics are going to reduce the symptoms of schizophrenia. Chlorpromazine, Thorazine, and clozapine are the ones that you should know. And remember, what do? They're going to block dopamine, right? Because excess dopamine is the culprit for schizophrenia. The next category of drugs are called barbiturates, and these are under the heading of anti-anxiety. Have you ever heard of the word anxiolytics? Yeah, it's not very common, but I've heard anti-anxiety drugs be referred to as anxiolytics. And here's some names of drugs that you should know. Barbiturates, benzodiazepine, Valium, Xanax. Those are the big ones. And probably the one that you've heard of is Xanax, and these are used for, quelling panic attacks. So Xanax work very fast, like in about 15 minutes, and the person is basically like it's a minor tranquilizer, so you are sedated. And the big criticism of anti-anxiety medications is that you're not fixing anything, you're just putting a band-aid over it. So they're highly criticized, they're not really solving any problems, and also you have to think they have that addictive quality to them. So once people start on them, it's really hard to stop. Probably the most popular psychotropic drug is the antidepressant. There are three kinds of antidepressants, but there's one that you really have to know the most, because these are the majority of the questions on the AP exam are surrounding antidepressants that are selective serotonin reuptake inhibitors, and we say SSRI for short. But the other two are monoamine oxidase inhibitors, or MAOIs, and if you go to your medicine cabinet and you turn around anything like Dayquil or NyQuil, it'll often say, do not take this drug if you're currently taking an MAOI. MAOI inhibitors often have like a bad interaction with other drugs, and these are like over-the-counter medications. Even things as simple as like nasal spray or Benadryl, or like I said, Dayquil, something like a decongestant, they don't mix well with MAOI. So MAOIs, even though they could be effective, they have like a bad mix with things, and there are even dietary restrictions with MAOIs, so they're not very popular. The second one there are tricycles. This is going to increase serotonin and norepinephrine, but again, they have that quality where they have like a bad interaction with other things as far as foods and other drugs. So the prom queen here on the slide is SSRIs. Number 3, selective reuptake inhibitors, and you should know some example of SSRIs like Prozac, also known as fluoxetine. Zoloft and Paxil are cousin drugs of Prozac, and they're all kind of related, but what do they do? Remember when we learned about the neurons? It blocks reuptake. So remember I did that little hand puppet show? When this neuron, right, shoots out a chemical, this one needs to absorb it, but if it doesn't absorb it fast enough, this one takes it back. Well, Paxil, Prozac, Zoloft, they block that reuptake mechanism. So it allows this slow guy to take that serotonin, and a person feels like natural mood elevation. So a lot of controversy behind these SSRIs, and I found an old documentary that I think was done in the 90s that really criticized SSRIs because they were given to kids, like too much was given to kids when they were too young and they were not being looked after or followed up with a doctor, and it led to some catastrophic results. So this little video, I don't recommend it, If you are squeamish, you don't like talking about things that are too serious or traumatic, I wouldn't watch this video. And I'm actually not even showing this in class, but there is a bad side to SSRIs, but this has been resolved and remediated by starting off with lower doses with younger people, and also keeping a close eye on people who are taking the SSRIs, and also letting them know if you feel more depressed, if you're having bad thoughts, to contact your physician or tell somebody, because this is not, typical. They weren't given those warnings back then. Today, they're definitely given warnings, and the warnings are located on the documentation. Like when you get your medication from the pharmacy, the documentation will have those warning labels today. The drugs for bipolar are called lithium salts, and lithium is a mood stabilizer. But that cute little float chart right there next to me, okay, that cute float chart is not decoration. You should look at it because it gives you a nice treatment plan for patients or clients that are diagnosed with bipolar. So the medication that you can give them is a mood stabilizer like lithium. You can also administer an antipsychotic if they are very manic, or they're delusional, or they could be kind of having these momentary lapses of psychosis where they're losing and they're breaking away from reality. So you can administer an antipsychotic, and additionally you can administer an antidepressant. They can have 3 different drugs: a mood stabilizer, an antipsychotic, and an antidepressant. All 3 of those could be administered to someone who's been diagnosed with bipolar. Electroconvulsive therapy has a bad reputation, but ECTs, as they're known today, they're still being done at outpatient centers, and even like Memorial Hospital, Cleveland Clinic, there's a lot of hospitals around us, right? They still do ECTs, but they do them for people who have very, very bad depression in which SSRIs and other drugs have not worked for them. So this is kind of like a last resort. What do you do with a client that is experiencing great bouts of depression? They're having bad thoughts, maybe even suicide ideation. What do? You can't send them home and wait for an SSRI to work 2 weeks later, because that's pretty much when the drugs kind of kick in, 2 weeks after they start them. When you don't have that ample amount of time, what do? ECTs is that remedy where they can, if they have severe depression and they're having the suicide ideation, they can go in for an ECT. ECTs are administered maybe once a year, twice a year. They're done under total anesthesia. The person is completely put out, and they're going in as an outpatient, which means that they go in the morning, right? They go in without eating, just like if they're going to have surgery. They can't eat after midnight. They put them to sleep completely under a general anesthetic, and then they're given something that makes them convulse. Now, the convulsion comes from the electric shock, right? The electric shock is given to the brain, and they're going into a convulsion on purpose. And then after the convulsion, they stop and they let the person wake up naturally. What does the person remember? Absolutely nothing. It's just like surgery. You don't remember anything. You're fast asleep. But when you wake up, they claim that they feel like an elevation in their mood. They're feeling that their depression has been lifted. So ECT does work. And like I said, it's administered once a year, maybe twice a year. One of the side effects that's pretty bad, though, is memory loss. That's probably the most severe side effect. And of course, you have a convulsion as a side effect too, but the big thing is the memory loss, which is why it's reserved for last resort, when nothing else has worked and the patient or the client is really very, very depressed. These are some alternative neurostimulation therapies. First, we have transcranial electric stimulation, which the current is much weaker than an ECT. Also, it has less side effects, and the effectivity is controversial. Some people claim that they feel better, and then some people are saying that it does nothing for them. So again, it's not as strong, but some people are saying that it does work for them. The transcranial magnetic stimulation isn't using electric shock at all. It's using very very heavy magnets. And it's an application of repeated cycle of magnetic energy to the brain. It's used to stimulate or suppress brain activity. And then lastly, we have deep brain stimulation. This is when the depression is resistant to both drugs and resistant to ECTs. It's used to treat Parkinson's. It's also used to this is brain surgery. So you're going in and you're implanting electrodes in the brain, in the SAD centers of the brain. It's going to stimulate these areas. It's going to let the person kind of rise up out of their depression. And this, of course, remember, because this is brain surgery and all surgery is risky, this is a last resort. This is a last ditch effort to make this person better. Drugs haven't worked for them. The ECT hasn't worked for them. And then deep brain stimulation would be considered after that. I made this little concept graph to help you learn about the different neurostimulation therapies, and I provided a picture so that you can see the different kinds. The next kind of therapy is no longer done. In fact, it's, not even legal, and it's called lobotomies. Have you ever heard of lobotomies? This is under the heading of psychosurgery. Lobotomies were first developed by Agus Moniz, and yeah, he got a prize for this, a Nobel Prize, if you can believe that. And basically, a prefrontal lobotomy is brain damage. They can go through the eye or they can go through the nasal passage, and they basically take like an ice pick apparatus and they poke it right through and they move it about, basically damaging the right hemisphere of the frontal lobe as well as the left hemisphere of the frontal lobe, leaving the client almost like in a vegetative state. They're able to walk, they're able to talk, but haltingly. They don't critically think. A lot of patients or clients would kind of revert to like a very immature kind of state, and people would kind of notice that they were very lethargic. And yes, some people did sustain more damage and they were not really, like, they were vegetables afterwards. And then other people, there were occasions where people died. Now, there are some famous people that had lobotomies, like Kennedy's sister. It was said that she was experiencing bouts of psychosis, and I'm not really sure what her diagnosis was, but she was given a prefrontal lobotomy, and then she was never the same after that. She was like in a permanently vegetative state, unable to fully express herself. It was really, really sad. And I provided some pictures over here of Rosemary Kennedy so that you could take a look. But again, remember, lobotomies no longer done. I know you've heard of hypnosis, but they do consider hypnosis to be a therapeutic kind of, a resource. Now, can everyone be hypnotized? No. You have to be able to relax and be open to suggestion. Some of the qualities of hypnosis are as follows. There's two ways it can work. Number one is dissociation theory. Dissociation theory is a dual processing state of dissociation. And we've talked about dissociative disorders already, so you kind of know what dissociation is already. And there's normal dissociation, like when we space out and we start to daydream, that's dissociation too. But dissociation theory regarding hypnosis is basically saying that maybe hypnosis splits the consciousness and the client acts on the post-hypnotic suggestion, and they kind of follow through, like they're dissociating from themselves, and then they're just following the suggestions of the hypnotist. Another theory is called social influence theory. The client is like an actor playing a role. If they're almost like food subjects, the hypnotist can guide them to feeling better. And what's interesting about that, it's almost like they're watching themselves from afar playing or acting out this role. So you are Elvis and you're on stage and you start to sing like Elvis or cluck like a chicken. You're playing the role of chicken. You're playing the role of Elvis. It's probably important to mention that when people are going through therapy, a lot of things that the therapist will suggest are some real lifestyle changes to help them. So what are some lifestyle changes they might suggest? Maybe meditation, eating healthy, exercising. This can influence both the brain and the body to work together to improve mental health. You know I like my charts. This is not a decoration either in your notes. It's found in your notes so you can study from it. And these are all the different kinds of therapies, the problems that they're supposed to remediate, the therapy aim, and the therapy technique. Know it. You know, it's probably really important to note that yes, it's good to diagnose mental illnesses early, but even better to prevent them. And it really does, it is worth taking a moment to talk about preventing psychological disorders and building a sense of resilience. And post-traumatic growth is something that the textbook talks about nicely. It's positive psychological change following a struggle with an extremely challenging circumstance, even a challenging life crisis. And building resilience, building that strength is very good to stave off serious mental illnesses.